All right. Good evening, everyone. Thank you very much for joining for the grand rounds. We are really excited. October is an amazing month because we have really feast with wonderful speakers from all across the country joining us. Last week we had Bob joining from Northwestern, Bob Bono, and we understood about aortic stenosis. We did reach upon some ideas about lipids and how it impacts complex cardiovascular disorders, including valvular heart diseases. We're going to continue the theme today in a different way. And coming in this month, I also wanted to remind everyone is that we have a talk on xenotransplantation on the 21st this month. So just be prepared for all of these wonderful talks. And we are so excited that we invite people and they all come and join us. Before we get started and I introduce the speaker today, let me share the slides so that we can get situated with our CME credits. So I'm going to just share the slides here quickly. Let me just change the display. All right, so the website continues to grow and attract a lot of people from all across. I was in last week at DeBakey, Methodist DeBakey at Texas Heart Institute. It seems like we have visitors from there who log in as well. So it's very popular. You'll see also today's presentation being presented there. For the credits for CME credits for today's session, please text 20416. You can do it now at 888-816-4893, or you could do later on as an SMS message within 12 hours. And if you have an active Rutgers Cloud CME platform profile, then you'll get the CME credits. And if you're desirous of having the maintenance of certification points actively obtain, you can take the brief quiz after the step one on the CME and go into the link and have the future 2024 as a room code. And if you answer the questions correctly, your ABIM profile will get the MOC credits directly through this process. Once again, we'll remind them within the middle of our talk, but please go ahead and get your CME and MOC credit as we provide them during this session. So now to introduce our speaker, I'm really, really honored and thrilled and to bring in to the stage Dr. Pradeep Natarajan, one of the most prominent physician scientists in preventive cardiology and cardiology genetics on a crossroad. He's the director of preventive cardiology and the Paul Fireman Endo Chair in Vascular Medicine and Mass General Hospital, associate professor and associate member of the Broad Institute of Harvard and MIT. He was in California where he did his molecular biology, and subsequently he came to Harvard in 2015 with MSc in biomedical informatics. He completed his internal medicine residency internship at Brigham and Women and his research fellowship in cardiovascular medicine and Mass General in 2015. And I was just going through his CV and I was trying to understand how do we summarize it. It's incredibly difficult when you have a CV of 120 plus pages. But I'm just going to try to do my best. What I found was an incredible passion in trying to do a worldwide do a mainstream work in coronary artery disease and using translational science and insights to really help us towards preventive cardiology. Dr. Natarajan currently, I must say, is busy clinically as the director of the preventive cardiology program, which has grown annually and has about 800 new visits, 1,400 follow-up visits. It does 4,000 exercise encounters, and it serves as a co-training experience for 8 fellows annually. He has specifically worked in the field of prevention and with the focus in coronary artery disease and genetics. He has been pioneer in human genetics consortia and methodological innovations. He has profound impact on areas of work which range from lipids to lipoprotein, coronary artery disease, spontaneous coronary artery dissection, peripheral artery disease, calcific aortic stenosis, aortic aneurysms, pregnancy, so on and so forth, with remarkable publication that range from very high impact journals like Nature, Nature Medicine, Nature Genetics, to JAMA Cardiology, JAMA, JACC, and so on and so forth. He's probably reviewed and made an impact in all major journals. He's associate editor currently of JAMA Cardiology and Science Advances. And amongst so many notable honors that he has had, I just wanted to pick up two of them in 2022. He was Jeffrey M. Haig Atherosclerosis, Thrombosis, and Vascular Biology Award for Basic Sciences in and Clinical Research from AHA. And 2023, he was the Joseph Evita Award from the AHA. He has funding, and I saw his funding records, like 6 or 7 pages of NIH, NHLBI, current and existing awards. He has multiple engagement from Apple, other industry partners. He has his what was also equally interesting in his CV record was his teaching profile included almost 8 pages of people with from medical student to residents to early career faculty members who have enjoyed his mentorship. He has 6 patents, 247 publications, and I think I can just go on and on. But what I'm really thrilled is today he's going to talk about something which is so relevant, and that's on lipids. With that note, Pradeep, thank you very much for taking our invitation and coming and speaking to us. But we want to really showcase you as a role model for someone who wants to be an academic medicine. And I think you're going to inspire our fellows and people who are going to learn from you of how, and I'm just incredibly amazed how in a short period of while, how much impact you have had in the field in general. So welcome and thanks. We're really looking forward to learning from you.
Thank you. Thanks so much for the kind and I think too generous introduction. So really excited to be with you all and share a very core concept in general cardiology is really the management of lipids to prevent the onset of atherosclerotic cardiovascular disease. You heard that we use epidemiology, human genetics to really advance many of these concepts with the goal of ultimately impacting clinical care. I'll highlight some of these things, but really this is intended to really provide a state of what the field is now and where we think things are heading. So my disclosures. So, core focus will be on LDL cholesterol because that is the principal strategy for lipid-based primary and secondary prevention for atherosclerotic cardiovascular disease. We'll talk about available and emerging therapies and other pathways as well, also related to lipids, really with the ultimate goal of improving atherosclerotic cardiovascular disease risk. And then also talk about new laboratory tests that one could consider as well too. So as I said, major focus on LDL cholesterol. We'll talk a little bit about HDL cholesterol and where we are there. And then triglycerides, Lp(a) and apolipoprotein B. So the lipids themselves are cholesterol and triglycerides. They're insoluble in the blood, so they get packaged into lipoproteins. These are large macromolecules that will contain cholesterol, triglycerides, and some other lipids like phospholipids. And then on the outside, we'll have other molecules, including phospholipids, to make them soluble. And the size is largely dictated by the relative amount of cholesterol and triglycerides. And the density is where these lipoprotein particles get their names. LDL, low density lipoprotein, HDL, high density lipoprotein, and there are some others. And they have additional proteins as well that help dictate their function. So in a standard lipid panel, you get the total amount of cholesterol and the total amount of triglycerides. And then you get the amount of cholesterol within HDL and the amount of cholesterol within LDL. So we'll talk about LDL cholesterol. So LDL cholesterol in the epidemiologic literature has a strong linear correlation, a monotonic relationship with cardiovascular disease risk. those who tend to have higher LDL cholesterol have higher cardiovascular disease event rates, and those who have lower LDL cholesterol have lower cardiovascular disease event rates. Now, statins have been shown to lower cardiovascular disease risk, and it seems to be proportionally related to the amount of LDL cholesterol lowering, suggesting that not only is there a linear relationship epidemiologically of LDL cholesterol and cardiovascular disease, but similarly, lowering it brings you down on the slope, strongly supporting the role of LDL cholesterol as a causal feature for cardiovascular disease. Now, people keep making newer LDL cholesterol lowering medicines because there is an abundance of empiric observations that suggest that optimal LDL cholesterol is probably much lower than what is quoted as potentially being in the normal range. Now, for most standard lipid assays, when the LDL cholesterol exceeds 130 milligrams per deciliter, then it is flagged as red, as being abnormal. And the average in the population is about 110, which is considered normal. However, if you look at non-human primates, other mammals, contemporary hunter-gatherers, their LDL cholesterols are about, in the 40s to 50s. And, human babies, when they're born, have LDLs of about 30, and then in the first year of life goes up to about 70. And so the reason why people keep making LDL cholesterol lowering medicines is because also empirically in the clinical trials, when you bring the LDL cholesterol down, increasingly so for those populations, you continue to lower cardiovascular disease event rates, suggesting that today, pretty much nobody has an optimal LDL cholesterol, and the optimal LDL cholesterol is likely much lower than what the population average is. And it's very interesting because it's, you can get a blood pressure that's too low, and you can get a glucose that's too low.
Could
you mute yourself, please? Sorry.
People continue to make these medicines because in the trials, when the mean LDL cholesterol continues to go down, the event rates go down. Again, different than blood pressure and glucose, where people can get symptomatic if too low. But this provides us some reassurance that these targets that we're increasingly reaching for are probably closer to what might be more optimal. Now, we have moved away, or the field has moved away from requiring fasting lipids, especially when focusing on LDL cholesterol, because the fasting or non-fasting state doesn't substantially influence the LDL cholesterol. But as you all know, the LDL cholesterol in the vast majority of assays is not directly measured. There are a lot of complexities to directly measure. And so it is calculated based on the total cholesterol, the HDL cholesterol, and the triglycerides. Now, some patients in the non-fasting state will have hypertriglyceridemia that can lead to more imprecision in the LDL cholesterol. So in practice, if I see patients who generally have abnormal triglycerides, then I recommend a fasting lipid panel. Otherwise, it doesn't really matter. Now, the conventional equation, the Friedewald equation, is imprecise when the triglycerides are high or when the LDL cholesterol is truly low. And increasingly, we're seeing patients with very low LDL cholesterol values because we are pharmacologically driving their LDL cholesterol down. And, sometimes I'll get calls or pages from colleagues because sometimes the LDL cholesterol will get read as, 0 or sometimes negative values. Some of those times it's because of the imprecision in the calculation. There have been a couple that have been advanced and now incorporated in guidelines as far as consideration of alternative approaches. One is the Martin-Hopkins equation, and that's based on a nomogram. Just basically, the Friedewald equation is total cholesterol minus HDL cholesterol minus triglycerides over 5. And through that approach, based on what the triglycerides are, that divided by 5 just ends up being a different value, and that seems to be pretty good. And then the Sampson NHLBI equation, which has a little bit more complex equation, which you can see there, but they all have little web apps where one can calculate. And you could see, B is the Friedewald equation as far as the spread when the LDL cholesterol is really low down at the bottom. And you can see that's improved with the Martin equation and then much better with the Sampson equation when you compare to the gold standard beta quantification for LDL cholesterol. In general, it's probably good practice if your lab is still calculating through Friedewald, of which it does commonly. Our lab does it as well. then you should just check and verify the LDL cholesterol through one of these more contemporary equations. Quest Diagnostics actually a number of years ago adopted the Martin-Hopkins equation. So in practice, especially for the patients that cardiologists see, because they generally have lower LDL cholesterols because of the medicines we prescribe, good to use one of these equations. Now, we won't focus too much on pharmacologic management of lipids or optimizing cardiovascular disease risk, but important to think about at least the diets that have undergone the rigor of a randomized controlled trial, because our patients read many different things about nutrition and cardiovascular disease, and most of that is based on nutritional epidemiology, of where there's a high degree of correlation, but a low amount of evidence that supports causal relationships. There are many reasons why people make the food choices that they do, and many reasons why people don't eat certain other foods. And a lot of these things are correlated with many other non-dietary factors, including income, education, food availability, exercise. And so most of those things are not fully explored in all of these studies. And so, people draw all sorts of different conclusions. So important to redirect them to at least where there is a randomized controlled trial. Not everything has undergone an event-driven randomized controlled trial, but the best that we have is the Mediterranean-style diet, which is in general a minimization of saturated fats, or at least not a excessive prioritization, and because this is what drives the LDL cholesterol, but prioritizing polyunsaturated fats. So extra virgin olive oil is the preferred cooking oil, fatty fish for those who eat fish, and then tree nuts like almonds, hazelnuts, walnuts. Prioritizing the fibers in the diets that comes from fruits and vegetables, minimizing the refined carbohydrates. That's white bread, white pasta, sugar-sweetened beverages, and other added sugars. Okay, and that overall has been shown prospectively to lower, compared to a standard low-fat diet, lower the event rates, cardiovascular disease event rates, of which most of the signal is a reduction in ischemic stroke events. Okay, so in saturated fat, and I focus on this because this is at least a macronutrient that is most closely tied to LDL cholesterol. You do want to minimize the total amount that patients are intaking for saturated fat, especially if you're also trying to control the LDL cholesterol. And as I said, the epidemiologic relationship with saturated fat and cardiovascular disease is complicated because there are many studies where, again, when people who eat low saturated fat, some of those folks will also end up eating higher in refined carbohydrates. That was really much more of a phenomenon about 20 years ago, but that is still in many of the epidemiological data sets that people assess. So because of this, you can often get, paradoxical signals. And so at least the Mediterranean style diet suggests to, instead of replacing saturated fats with carbohydrates, which was often the case when the field would make recommendations about low-fat diets, but instead to prioritize the macronutrients of polyunsaturated fats. There's a really nice table, and there are many such out there that really describe these kinds of heuristics. And in my practice, I largely go through these things together with patients, and then they are also meeting with the nutritionist to operationalize these as well. The most important reason is, you and the patient could probably readily identify the foods that they should eat less of. But if you start to cut lots of things out of the diet, patients won't really know what is palatable and healthy that they should reintroduce in their diet, which is critical, obviously, not only for maintaining the nutrition, but also the durability for this kind of diet. Okay, so back to the standard lipids. So, these are the different targets that have been proposed in the 2018 ACC/AHA guidelines, which is the latest, the 2021 ESC guidelines. I'll say why I've introduced this here. And then in 2022, the ACC had a non-statin consensus. Okay, there's not technically a formal guidelines, but often can be used to justify certain medicines. So in general, the statin eligible groups for primary prevention are all the same. So severe hypercholesterolemia, diabetes, high estimated risk, and then those who are borderline estimated risk as well too. Now, there's been always some controversy, at least over the last 10 years, about targets, because in 2013, that was the preceding ACC/AHA guidelines. The guideline writers did away with the targets because no clinical trials or clinical trials in general are just testing medicines. And the medicines lead to proportional lowering, but are not necessarily specifically testing targets. that has led to a lot of confusion. A lot of people still use targets. And as you can see, the 2021 ESC guidelines uses targets, and the 2022 ACC is kind of returned to targets. One thing you'll see is that the ESC guidelines in general are a little bit more aggressive than the ACC, than the HA and ACC. And in general, we in the US guidelines tend to lag a little bit. Major challenge is the identification of high-risk individuals when they are younger. In the ESC guidelines, they actually just say go down lower, as opposed to, like a 7.5% 10-year risk cutoff for intermediate risk. For somebody in their 20s, you could potentially go even at 2.5%. That hasn't been well prospectively assessed. That's not currently in the US-based guidelines, but individuals who are younger, early middle age, who are starting to manifest modifiable risk factors, those are the folks to be aggressive in managing their risk factors to prevent lifelong future risk for cardiovascular disease. Now, a new term that was introduced in the 2018 guidelines is risk-enhancing factors, because there are lots of patients that are in this borderline to intermediate risk range. The borderline is 10-year risk 5 to 7.5%. Intermediate risk is 7.5 to 20%. Okay. And we know that not all of those patients will end up going on to have cardiovascular disease. And so there was much more the notion of shared decision-making that was introduced into these guidelines, and the inclusion of additional factors that can help potentially upclassify the recommendation or strengthen the recommendation for a statin. These are additional factors that have also been associated with increased risk for cardiovascular disease, because in general, we allocate preventive medicines largely based on estimated risks, the number needed to treat largely being driven by greater absolute risk reduction from just starting at higher absolute risk. So assessment of each of these factors can help in that discussion. Understanding that everyone in that range is technically eligible for a statin, but these additional factors may help in that discussion. But as you might expect, and probably anecdotally from your experience, there are a lot of patients where they're still unsure. And coronary artery calcium scoring, that's the quantification of calcified plaque through a continuous score from non-contrast cardiac CT, has been around for a long time. And so far, at least, third from age and sex is pretty good as far as 10-year risk prediction. And then, kind of first introduced in these 2018 guidelines really as the next step, saying if there is still equipoise, meaning, those patients is still reasonable to consider a statin. But if patients aren't convinced, a clinician isn't convinced, this can be another test to help us refine whether somebody should be on a statin. And the reason why is because the risk prediction is pretty good. You can see individuals who have a calcium score of 0 over the subsequent, 5 years have a low event rate, despite the name is not necessarily a 0% event rate. And then with each of these categories, the risk goes up. And then most importantly, and how it's often used in clinical practice, is if there is a calcium score of 0, especially for those patients where, based on clinical criteria, it's still reasonable to consider a statin, but then get down classified because of the absence of plaque. So here, this looks at the change in its ability to down classify risk. And compared to many other factors, it is among the best as far as decreasing risk. Again, doesn't bring it to 0. This is, I think, some of the complexities of a calcium score of 0 just by its terminology. But it does provide some reassurance, and particularly for patients who are otherwise disinclined, this may be reasonable to use to kind of defer a statin. Now, importantly, that none of that has been assessed in a randomized controlled trial. We don't know whether it's safe just for people who have clinical risk factors to just put them on a statin and not prolong and wait to the development of atherosclerosis. Now, there are ongoing studies to assess this, and that's part of the discussion with patients, especially in this shared decision-making, that if they have a calcium score of 0, but do have additional features, for some of those patients, we set the stage where we can say, okay, this provides reassurance, but maybe the motivation is to prevent the onset of plaque, and still some patients do initiate statins. So I think, important to have a discussion beforehand with patients what to expect with the calcium score, what it's assessing, what it's not assessing, and where we can provide reassurance. But in general, the risk prediction is pretty good for the next, 5 to 7 years, and depending on the age, may prompt the reassessment. And again, none of these things have been assessed in randomized controlled trials. This is often what's done in clinical practice. And we do know that it is a very good predictor for cardiovascular disease risk. So not unreasonable, but these paradigms do need to be better assessed in clinical trials. So the 2022 ACC actually did lean in more to coronary artery calcium scoring. So they did say that, if it's performed, one can consider deferring a statin if the calcium score is 0 and then remeasure over the next 3 to 5 years, again, depending on the age, unless any other high-risk conditions are present. And we'll talk about that in just a moment. And then really based on how much plaque there is, to be increasingly aggressive on the LDL cholesterol targets, because we know there is a dose-dependent relationship between the amount of atherosclerosis and the future cardiovascular disease risk. There's been some studies that try to estimate what is the same as secondary prevention, because the guidelines don't technically call this secondary prevention. It is at least currently, it is in a primary prevention pathway to better risk stratify patients, and secondary preventions traditionally have been patients who have had symptomatic cardiovascular disease, because that in general has been the inclusion for clinical trials. But among asymptomatic individuals, a calcium score of greater than 300 seems to have a very similar absolute risk as clinical symptomatic coronary artery disease. The major times to not check, let me see if I have this here. These are, so down here, so the higher risk conditions, these are conditions that have substantial increased risk for cardiovascular disease, where it may not make sense to really wait, because by the time that you wait, there may be sufficient risk even with a calcium score of 0. So at least diabetes and cigarette smoking. The family history part is a little controversial, a little bit unclear why that's in there, because there are many reasons why there might be a family history of premature cardiovascular disease, maybe related to established risk factors in that individual or not. So that part is probably a little bit confusing, but for those who have other overwhelming reasons that they are high risk, like diabetes and smoking, calcium score should not be used as a basis to defer therapies in those patients. Okay, so secondary prevention. So again, the comparison across the three, the ACC-AHA, they did this kind of weird thing in 2018 of introducing a target just for a subgroup of atherosclerotic cardiovascular disease that is very high risk. The reason being is that these were the first guidelines after the introduction of PCSK9 inhibitors in the clinic. Still lots of concerns about cost and availability, and thinking about the number of patients who are on statins, and people are, guideline authors felt like they were responsible for potentially the healthcare economics. Actually, if you do a text search of cost is all over those guidelines, whereas in the prior one, 2013, cost is there once, just talking about how statins are cost effective. So that was among the things, and basically just patients who had additional factors for recurrent events. Those are the ones to be particularly aggressive, and those are the ones to prescribe PCSK9 inhibitors. Since then, 6 years ago is a long time. Practice has evolved. There's been a lot more comfort in just achieving LDL cholesterols less than 70 in secondary prevention, kind of prompted by the ESC guidelines, which have increasingly permeated practice of an LDL cholesterol less than 55 and for secondary prevention, to now introducing that to a very high risk group. And some of this has changed, partly because now there are more and more medicines. There's more ways for patients to achieve very low LDL cholesterol. And based empirically on the clinical trials, we do have more comfort with lower LDL cholesterols, and we increasingly see that at lower and lower values, there are lower event rates. So we'll see what the next ACC-AHA guidelines show, but there are a lot of folks that are using sort of the ESC prompts to do even lower LDL cholesterol. Okay, so coming back to statins, what are the potential downsides? And best to always assess this in the context of randomized controlled trials. Now, what patients hear about and read about, and what is probably most recognized, is the association with myalgias. Now, it turns out in the vast majority of randomized controlled trials, the statin group will report myalgias, and the placebo group will report myalgias, and the event rates will be pretty similar. We'll come back to that in just a moment, but that basically suggests not necessarily that myalgias are in everybody's head, but the true prevalence of statin-associated myalgia is probably much lower than what people think. LFT abnormalities are reasonably common, but the rate of overt statin-associated hepatotoxicity is exceedingly rare, such that actually guidelines for a number of years, really since 2013, have discouraged against routinely assessing for liver function test abnormalities, because it's not unreasonable that you'll see it, but it usually is not in a range that prompts any change. There is a signal for type 2 diabetes, again, not seen with any single clinical trial, but in a meta-analysis has been observed. Now, the risk related to diabetes is pretty modest compared to the cardiovascular disease benefit, particularly in statin-eligible groups. However, in a low-risk group where there may be cardiovascular disease benefit, but there may also be a risk for diabetes, those kinds of things may cancel each other out. Maybe that is a reason why not to put statins in the water, for example. But in general, for the folks where this is recommended, this is not generally a clinical concern. There have been very recent studies, innovative studies, to really try to understand statin-associated myalgias. These are innovative N of 1 trials where, as I said, before you would, or in a randomized controlled trial, you compare the rates between statin and placebo. Here, you take patients where the patients and the clinicians are convinced that the patients have statin-associated myalgias, and for them, in a blinded fashion, randomly go back and forth between a statin and a placebo. And you can see, at least for this plot, there isn't a strong correlation between the reported symptoms and whether on a statin and placebo. And for here, you can see when patients have an act of being on a pill, either a statin or placebo, or coming off of a pill, those perceptions substantially change their perception of symptoms as well, too. And so for many of these, it suggests that there's likely some underlying muscle disorder or some other underlying issue that is driving the perception of the symptoms. But often, I think setting these things up, because again, patients are going to read on the internet, they're going to expect to have symptoms. And if you look at the population that's on statins, generally middle age, we experience lots of musculoskeletal issues, and patients will likely first will attribute it to a statin. So I think setting up the stage of what the expectation is, vast majority of the time, the symptoms that they're experiencing is unlikely to be related to the statin. Okay, but as you know, we don't have a great biomarker blood-based test or imaging test to do this. So a lot of this is clinical in its assessment. All right. Importantly, there is one important modifiable factor for statin-associated myalgia that's untreated hypothyroidism. So make sure there's some recent TSH that's been assessed before starting a statin. I said there's no recommendation, or we discourage routine assessment of LFTs, but good to check LFTs at baseline. And then if the LFTs are at baseline, then that's fine. Then there's nothing to follow going forward. Okay, as I said, there have been other non-statin medicines that have been associated with reduced cardiovascular disease event rate. So ezetimibe is one. Modest reduction in LDL cholesterol as a result, more modest reduction but significant for cardiovascular disease events. As we know, PCSK9 inhibitors, at least 2 of them so far, monoclonal antibodies, have been shown to lower LDL cholesterol and lower cardiovascular disease event rates. The timeline for these trials have been shorter than statin randomized controlled trials, so the effect estimates are a little bit less despite larger LDL cholesterol lowering, but pretty similar in their effect estimates. As we know, there is another PCSK9 inhibitor that is commercially available. This is an siRNA, so it allows for longer interval dosing of this PCSK9 inhibitor. Medicine is called inclisiran, has been shown to potently lower LDL cholesterol with less frequent interval dosing. And we'll know soon whether that lowers cardiovascular disease event rates, but we expect if they're compared to the, what has been reported so far, if there continue to be, reassuring side effect profile and this amount of LDL cholesterol lowering, we would expect lowering for cardiovascular disease event rates. How inclisiran is permitted in clinical practice and how that's sequenced, there's a lot of nuance based on the payer. Now, interestingly, as some of you folks may know, is that, obviously the medicines have a separate drug benefit. Whereas inclisiran, as it was developed and really marketed, because Novartis that makes the medicine probably thought that there would be an economic advantage, or at least a market advantage, is that this has to be administered in some healthcare facility. in a doctor's office, in an infusion center, but this is through the health insurance benefit. So it leads to a lot of complexities because, most clinical practices, at least cardiology clinical practices, don't even give flu shots in the office. So there is a workflow challenge, but it also leads to some challenges in actually getting the medicine approved, but there is variability in its coverage. But I think, we'll hopefully know a little bit more over time, just about at least the event rates, and then maybe there'll be a little bit more equipoise in choosing. There's another pill like ezetimibe called bempedoic acid that is shown to lower LDL cholesterol and lower cardiovascular disease event rates. This is a medicine that inhibits an enzyme called ACLY. ACLY is in the HMG-CoA reductase pathway, the cholesterol synthesis pathway, or at least de novo lipogenesis pathway. Bempedoic acid is a prodrug, meaning when ingested, it's inactivated, and then it gets activated only in the liver. And it was designed to prevent statin-associated myalgias because it does not get activated in the peripheral tissues like the muscles. So in this clinical trial, is patients actually who had statin-associated myalgias and had to actually sign on the form that they had statin-associated myalgias and they were deferring potentially life-saving statins to be in this clinical trial. Anyway, showed that it was beneficial. Couple important side effects. There's an increased risk for gout and an increased risk for cholelithiasis. That's because the medicine impedes the urinary excretion for uric acid. That risk for gout and cholelithiasis seems to be primarily in patients who have had either gout before or who have hyperuricemia at baseline. So, and any of these patients who have complications or complicated in their lipid management, always ask about prior history of gout and then check uric acid levels. If each of those are flagged, then I would not prescribe this medicine. The one nice thing about the medicine is that there is actually a combo pill with ezetimibe because the two have similar potency. When combined, we'll have, potency of, roughly a high potency statin. And that combination actually does not have an extra copay for patients. And so when patients are on statins, ezetimibe, and if they are not sure about being on a PCSK9 inhibitor, not sure about being on an injection, the addition of bempedoic acid can just be the addition of a combo pill. So it still actually leads to two pills, the statin plus the combo bempedoic acid with ezetimibe, and can be more acceptable to patients. And then there is one other lipid-lowering, LDL cholesterol-lowering medicine that currently is only for patients with homozygous familial hypercholesterolemia. Okay, so we reviewed the key statin-eligible individuals, and then we have increasingly more and more options, and there are more individuals that are thinking about other ways to inhibit PCSK9, and so we'll continue to learn across time what is the appropriate approach to sequence, but my hope is that we can better customize this based on what is appropriate for the patients, because in the end, it really is the LDL cholesterol lowering that matters the most. Okay, HDL cholesterol. HDL cholesterol has had this inverse relationship with cardiovascular disease. That's why it's been termed the good cholesterol. Okay, but we now know that many randomized controlled trial medicines that have tried to raise the HDL cholesterols for patients who have lower HDL cholesterols have generally not had an improvement for cardiovascular disease events. One was positive, and that might have been driven more for the LDL cholesterol part. Okay. Now, there is still one medicine that is being assessed that does modulate HDL cholesterol. It's also the family of CETP inhibitors that have been assessed. The medicine is called obicetrapib. What is different about this medicine is that it even more potently lowers LDL cholesterol. So, whether it does improve cardiovascular disease events, it might be more related to its LDL cholesterol than its HDL cholesterol, but it at least does it from a mechanism that is not assessed through that's not done through statins, bempedoic acid, ezetimibe, or PCSK9 inhibitors. So may have a complementary role. There's been one medicine that's also assessed through an infusion of ApoA1. This is the primary protein that determines the HDL particles, because some people still say that it's there's a functional property of HDL beyond the HDL cholesterol concentration that is important for coronary artery disease. One of HDL's role is to remove cholesterol from peripheral tissues. That's called cholesterol efflux. That recently has been assessed in a clinical trial in the context of MI, and that was a null clinical trial. Okay, so it's still a very good predictor. We should not be using it as a good cholesterol because it really is probably not the HDL cholesterol itself. It seems to be correlated with other things that have greater plausibility as far as having a role with cardiovascular disease, but still much to be assessed. But there are still things kind of in the that are HDL cholesterol adjacent that are still being evaluated for cardiovascular disease. Now, triglycerides are inversely correlated with HDL cholesterol. And so like LDL cholesterol do have a positive correlation with cardiovascular disease. So there's been some interest in saying, okay, if it's not the HDL cholesterol, maybe it's the triglycerides. Now, there's a medicine that has been assessed that lowers triglycerides that has been shown to lower cardiovascular disease events. This is icosapent ethyl, or Vascepa. This was shown in a secondary prevention population to lower event rates, similar effect estimate actually as a statin, with pretty consistent effects across populations. And among individuals that have reasonably controlled LDL cholesterol, but their triglycerides are on the higher side. Now, icosapent ethyl does lower triglycerides, but not by that much, by about 20 to 25%. So this effect estimate is actually much larger than what one would expect, purely from the triglyceride lowering, suggesting that there may be other issues. But there has been a lot of complexity in the interpretation of this clinical trial, the REDUCE-IT clinical trial. All the other, there's been tons of omega-3 fatty acid clinical trials that have been assessed. Now, icosapent ethyl is purified EPA. So DHA and EPA are the omega-3 fatty acids that are in fish. ALA is an omega-3 fatty acid that is found in plants like flaxseed. Also, all these others have been null. Most of those have been lower doses, but there's been a recent, trial, the strength trial, which had also similar dose of omega-3 fatty acids that was null. There's been some concern that maybe it's the placebo that led to a problem, because one way to have a positive clinical trial for the investigative agent is for the investigative agent to work at lower event rates, or have the placebo cause harm. Now, it turns out the mineral oil placebo, they had to do it so that it looked like a fish oil. It does impede the absorption for statins, so it actually led to higher LDL cholesterol. It was also observed that CRP also went up in those patients. So my guess is that the true effect estimate is probably not as high as reported, but lower. That trial was published basically at the same time that the ACC/AHA guidelines had come out, has not really permeated broadly in cardiovascular clinical guidelines, and still a lot of equipoise in how to interpret these. There has been since others, so pemafibrate is a fibrate, so PPAR gamma inhibitor, that is known to lower triglycerides. Secondary analyses suggested that this approach may lower cardiovascular disease events. So that was recently assessed prospectively in the prominent trial, and that trial was stopped for futility. In the end, there was no difference in event rates. And how you lower the triglycerides matters, because lipoproteins, when they get emitted from the liver, they start as triglyceride rich, and then they get processed ultimately to LDL particles. So one way to lower triglycerides and triglyceride-rich proteins is to basically promote that catabolism to LDL cholesterol. So what happened here is that triglycerides went down, but LDL cholesterol went up, and that ultimately led to a null effect. But there are now medicines actually that have been prompted in development based on human genetics, much of the work that we do, that are now getting into clinical development. Now, the story of why PCSK9 is in the clinic is based on human genetic observations of individuals who are naturally genetically deficient in PCSK9, appearing to have very low LDL cholesterol and seem to be protected from heart disease risk. That has been recapitulated now in clinical trials in broad populations. And we and others have observed this for two triglyceride-related genes, ApoC3 and ANGPTL3. And now medicines have been developed, have been shown in phase 3 that recapitulate those lipid effects. And now the phase 3 trial programs are getting started to see if that also will recapitulate the human genetics for the cardiovascular disease effects. So still much that is going on with triglycerides. And where the meat is seems to be where the human genetics are guiding us, based on what we have known with a parallel path through PCSK9. So in the guidelines right now, triglycerides are really to prevent pancreatitis, when folks have severe elevations. For many of the patients, severe elevations in triglycerides are often correlated with very poorly controlled diabetes, and optimization for the diabetes often will improve the triglycerides. But really, the principal goal is to prevent pancreatitis as a consequence of severe hypertriglyceridemia. Where there's more moderate elevations, you could consider icosapent ethyl, lots of caveats, probably patient specific. But again, icosapent ethyl is probably doing other things. It really is not just the triglycerides. And there is much more that we'll learn, I think, over the next 5 years. Lipoprotein little a, or LP little a. So LP little a is not in the standard lipid panel, but it is an LDL-like particle, meaning it has cholesterol and triglycerides, has many of the additional features of LDL. It has this additional protein called ApoA. That's where it gets its name. And ApoA can have a variability in size, but about 20% of individuals has this elevated. And individuals who have it elevated have a greater future risk for myocardial infarction and ischemic stroke. And there's an abundance of literature that suggests that it may be a causal factor. And it's almost exclusively determined based on genetics, whether you have it elevated. So individuals who've had premature events or family histories of premature events, that's where the diagnostic yield is higher than 20%. So the ACC-HA uses it as a risk-enhancing factor to help prioritize statins in primary prevention. But the European guidelines actually say because this is a genetic factor and is otherwise not assessed, all adults should have it as a one-time assessment. And there's some controversies there, and we can talk about it. But there's an emerging recognition at minimum because there are now increasingly medicines that are available, or at least that are in investigation to test whether this is a viable pathway to optimize risk. We do know from secondary analyses that individuals on PCSK9 inhibitors do have lower lipoprotein little a when it's elevated, and there seems to be an added benefit for those patients when they're on a PCSK9 inhibitor, suggesting for those who have high LP little a and you're considering a PCSK9 inhibitor, there may be an added benefit for both the LDL cholesterol lowering and the LPA lowering. It's not much, basically about 20%. But as I said, there are medicines that are in evaluation. Okay, now I'm going to just quickly go through this last part just to make sure that we have time for questions. So ApoB, there's emerging interest in using ApoB because a unifying feature of all atherogenic lipoproteins is that they all have this molecule ApoB. It turns out that is a better predictor for cardiovascular disease risk than LDL cholesterol. This is kind of a comparison across all of these, and the strongest signal for all these kind of LDL cholesterol related factors is ApoB. And so there's interest in potentially using this as the principal factor in LDL related therapies. Right now, again, this is from the 2018 guidelines, is to use it as a risk enhancing factor. And ESC guidelines says to use ApoB maybe in scenarios where LDL cholesterol is unreliable in assessing atherogenic lipoprotein risk. These are individuals that generally have smaller LDL particles, so actually have more LDL particles than their LDL cholesterol would otherwise suggest. ApoB is basically a rough surrogate of how many LDL particles there are. So this is an evolving space. There, I suspect that in our guidelines, it will evolve such that we're using ApoB more. The way that I use it in practice is where when people achieve what I think is their LDL cholesterol target, I verify with ApoB. ApoB, in general, the target is roughly similar. It's about 10% lower. But if they're not at that target, because some people, especially where there are some metabolic abnormalities, some folks will actually have higher ApoB. And so in those scenarios, LDL cholesterol is not sufficient. Really, you got to follow the ApoB and treat to the ApoB. So we covered a lot because there's a lot here, and this is an evolving space. But importantly, we have continuously lower and lower targets because we can, but also empirically, it's clear that none of us have optimal LDL cholesterol targets. The prevalence of hypercholesterolemia is probably close to 100% just based on all the emerging data. All of this stuff pharmacologic should be done in concert with dietary modification because often that can help stave off potentially the addition of additional medicines for some patients. And really focusing on the LDL and LDL related pathways is where most primary and secondary prevention is. With those who have elevated triglycerides, in secondary prevention, icosapent ethyl is a reasonable consideration. for those who also have elevated Lp(a), PCSK9 inhibitors should be considered. Importantly, they don't have a label for only Lpa lowering. Really, these are for patients who are on a statin, LDL cholesterol is not sufficient, but they also have higher Lp(a). Number 2 agent I would reach for is PCSK9 inhibitor. Many people may not know this, but ezetimibe, even though it's generic, easy to reach for, actually does not have an FDA label for secondary prevention. There's a complicated history why that is. So you have a justifiable reason for secondary prevention to add on a PCSK9 inhibitor next, and this is a good scenario for that. And then ApoB is still evolving. All right, I think we have some time for questions.
Fantastic overview, Pradeep. And I think I'm just amazed that in like less than an hour or maybe even 45 minutes, you just covered everything that is probably known in the space. And I think there will be so many questions that would be required to be addressed, and maybe people will be interested to ask you. But one question I wanted to ask, I think your institute, particularly Sekar Kathiresan, and all of you are working very much in the whole pipeline of the drugs that are genetically trying to address dyslipidemia. Do you think in the near future it's possible that you could have just a vaccine-based approach, like you take a couple of shots and the pharmacoeconomics of that may be equivalent to the outcomes of taking statins and all the other drugs, plus the non-compliance and everything that is existing? It's a complicated question, but what do you think? How far are we from that?
Yeah, not too long before it's feasible. Okay, now actually getting it to the clinic will be challenging. A lot of this is really acceptability and the economics and who the stakeholders are. So, obviously the patients themselves, they're likely for a condition that they may not have a severe affliction for. Like, for example, the one FDA-approved gene editing-based therapy is for sickle cell disease and transfusion-dependent beta thalassemia. These are folks that are sick. They're in and out of the hospital. And so reaching for this kind of curative therapy often makes sense also for the patients as well, too. And this is, even though it's, basically changing the genome, but for a particular population of cells, that is actually done outside the body. So far, we don't have any FDA-approved therapies where the gene editing is introduced in the body because it can go to any tissue. So there's a lot that needs to be done. And what are going to be the studies that are necessary to convince prescribers and patients that this is a safe thing to do? In general, these patients have to be followed for like 20 years. All right. So it'll be feasible to do this. But like that part, that one stakeholder, the patient and the provider, when will they be convinced? When there are, increasingly other options. But, early recognition of risk factors, earlier addressing LDL cholesterol likely will be very important and very, very substantial in ultimately reducing cardiovascular disease risk. Many people feel that the reason why ischemic heart disease continues to be the #1 killer is because LDL cholesterol is not adequately addressed. Now, importantly, that's not the only driver. I would say over the last 20 years, insulin resistance, obesity are now profound drivers. The distribution of risk factors and the influence really does change over time for a wide variety of complicated reasons. So we can't be blind to the expectations. We will likely not cure cardiovascular disease because there will be other pathways that will be critical as well. So I think it's complicated. I think it will take time to get there. I do think we should ultimately get there. I don't know what that timeline will be, but I'm glad that we are on the path to get there.
Fantastic. Second question, I was just at a symposium over the weekend, and there was a panel discussion on how much imaging and the ability to characterize the plaque early on is actually changing the whole paradigm of secondary prevention. I mean, by far and large, I think we call secondary prevention mostly as post-MI secondary prevention. But now, if you have a plaque and you have a 40% stenosis, but it's a high risk characteristics, you could actually follow these people up and stabilize them. And do you think it's a new area we are entering into where you could use the word precision imaging or precision therapeutics? It's very exciting that
Yeah.
Question that is coming up, although, is yeah, precision imaging and precision therapeutics, but at what cost?
Yeah, no, lots of good points. Yeah, I think my hope is that at minimum we can get to the point that we recognize that subclinical atherosclerosis is more on the spectrum of secondary prevention, but can be done in a more sophisticated way. Because people many times in the community or in practice, many people say, okay, calcium score of 1, that's secondary prevention. Yeah, that's pretty different than a calcium score of 1,000. Calcium score of 1 also is very different if it's somebody who's 40 years old compared to somebody who is like 80 years old. So lots of context, lots of things that we need to have much more sophistication than how we currently have it today, which is kind of like in this weird pipeline pathway, which is like, if you have it, then then think about it. And then importantly, as you highlight, even the plaque characteristics that you get for symptomatic patients, there is additional information there that we still don't know really how to use, and what are the primary prevention implications, because we don't really have the data sets in unselected populations to really understand what those implications are. But as you probably know, there's a lot of development in these and understanding these imaging-based features, and then prospectively trying to treat based on those imaging-based features. But all that stuff is happening now. And so I think the image-based classification of what we do on non-contrast cardiac CT, I think, 5-10 years, that's going to evolve. I think importantly, we need to better understand how we track the disease through imaging as well, too, because patients really want to know, right? Like the best that I can say is the medicine's working because, statin's working because the LDL cholesterol is low, or your antihypertensive is working because the blood pressure is fine, or, your A1C is okay. But they are like, they're doing this not to make the numbers look better. We're doing this also not to make the numbers look better. It's to improve the trajectory of the disease. And there is a long subclinical phase, and we have the opportunity to track it through those phases and optimize our therapies that way. That will take even more time. There's a lot of research infrastructure that needs to be developed. But I think we'll get there because there's lots of motivation to get there. Cost will be a big part, right? Because like a lot of what is happening today when people get, coronary artery calcium scoring and they get repeat testing, some people will have events, some people will not. There are costs that are generated. CCTAs will be more expensive. There'll be other things that people find. These have to be assessed prospectively to understand these issues. So I think as a field, we've all gotten increasingly comfortable with cardiac CT, but we're doing a lot of things that we just have lots of outstanding questions for when we're putting so much stock in this and not really understanding what the trade-offs might be, at the individual patient, at the economic level as well, too. And, this is an interesting area because like no company, no device company, no imaging company wants to do an RCT of coronary artery calcium scoring. You need like, the federal government or some nonprofit or somebody else who cares to do this. And it's hard. There is some new study that is spinning up in primary prevention for younger individuals and subclinical atherosclerosis, and maybe we'll get there. But yeah, I think, again, another important plug that we really have to do randomized controlled trials, not just of pills and medicines, but of these kinds of paradigms.
Yeah, I think there are some questions coming up, but I wanted to just point out one more question to you in terms of our fellows and trying to inspire them. So with all of these drugs and all of these trials and all of this work, imaging and therapy that is happening, do you think we are poised at a subspecialty, either combined with therapeutic intervention with imaging or something like you're already doing, which is as attractive as any other subspecialty like interventional cardiology? Particularly, I find it fascinating because this is more structured. You are outpatient based, but you have the same degree of excitement. I'm not sure what are your thoughts about as a subspecialty? How do we attract the next generation of people to get into this?
Yeah, I mean, this is such an exciting space for development that intersects, research, lots of innovations in biomarkers, data generation, direct implications for a lot of stuff that's happening in AI, which largely is prediction of the common cardiovascular diseases, and really now much more precisely identifying who's going to be at risk and more precisely identifying what to do to reduce their risk that maybe you might do something different compared to the others. So, we didn't talk about genetics and other things, but that is what we are focusing on, because, the imaging is basically the end product, the readout. We also still need to understand what those root factors are to better, prevent the progression of the disease process. So it's going to be an intersection and combination of those things. And that, involves entirely new skill sets and understanding a wide variety of features, synthesizing the data. But there is lots of synergy with drug development, with devices, with, data companies. So I am clinically active, but I spend a lot of my time doing research, but interfacing with so many different entities, so many companies. I have a lot of flexibility in my time. I really try to convince people that doing research is actually a lifestyle specialty. But when you do like interesting and innovative things, and you're like moving the field one, it's good professional fulfillment, but you can do this in a way that actually is, financially attractive as well too. So I encourage, and for the fellows who are listening to this, vast majority of people who are starting, like all of this stuff is pretty new, that people generally are entering these research years who are like just really good clinical cardiologists, are starting to develop passions in certain areas. And once you know, like, what are the important problems, what are the outstanding questions, then that's how you do impactful science, right? Like it really starts with understanding those questions. And so most of those folks don't then know how to yet address the question, but those are all learnable.
Great. Let's take some of these questions. So there does not seem to be how low is too low for LDL, and de-escalation seems unnecessary for secondary prevention. Is there data on how high is too high for HDL? I've seen some patients with very elevated HDL, 80s and 90s, with normal LDL and TG. Is there a harm? What is the next step?
Yeah, there's, some complicated, likely confounded epidemiological literature that suggests that maybe there is a U shape with HDL, where those who have very high HDL cholesterols, 90s and above, that there may be an uptick. Hard to know what that means. In general, those who are having higher event rates also have higher LDL cholesterols. So there's never really, I can't conceive of a scenario where the LDL is normal, where I would need to start medicines just based on that. They're extremely rare, or at least one rare genetic finding that has been correlated with higher HDL cholesterol and higher cardiovascular disease risk. But that's, I wouldn't recommend necessarily genetic testing in that area. So the literature is kind of confusing. So far, the data does not suggest that that's a causal relationship. Just like everything else with HDL cholesterol, there's probably something else explaining that.
Great. And Dr. Hamrani asks, what are your thoughts on using LPA and ApoB or CAC or CTA in diabetic patients, 1 and 2, who are recommended moderate intensity statins to begin with? Do you utilize it? All diabetics are not equal.
Yeah, so I do agree that all diabetics are not equal, but diabetics do have a pretty high risk for cardiovascular disease, that it is still very reasonable and recommended that all of them be placed on statins for more aggressive LDL cholesterol lowering. Now, I think if one were to use any of these other medicines to change that recommendation to say that they should not be, there's a potential risk for harm for doing that. So that would, like, if that is a paradigm that's being proposed, that has to be assessed in a prospective randomized controlled trial. And again, it's basically a statin. Statins have been around for decades or in widespread clinical practice. The harm of that proposition of a statin in a diabetics is exceedingly low, and the economics are overwhelmingly favorable. So doing additional tests to de-risk not only is the prospect of harm, is the prospect of just added costs. So if that were to be a serious paradigm, that has to be assessed prospectively.
Great. And I don't see any other questions. So I want to thank you for your time and for inspiring us. I think there's one more just came up. At what levels of LDL do you back off on statin dose?
Very uncommon. I mean, certainly you can overshoot. I think if you're getting to like the 20s of LDL cholesterol, when you have verified that based on the calculation, you could. However, first I would just check what the ApoB is, because the ApoB could be higher, right? So if it is higher, then maybe you should keep it at that level. So maybe in the 20s, or ApoB in the teens would be a reasonable time to back off, but solidly keeping people less than 55 is probably the way to go for individuals where there is a reason to be on a statin.
Fantastic. Thank you very much, Pradeep, for giving this talk. And I think we'll hopefully be able to bring you back in person sometime next year, and look forward to maybe joining us and having more deliberations on your research. Thank you very much. Thank you, everyone.
Yeah,
Good night.
my pleasure.
Bye-bye.